Hello, I'm Scott Kurtzman. I'm a member of the Executive Committee of the American Joint Committee on Cancer. The purpose of this talk is to describe staging, which is the language of cancer, and the role of the AJCC in staging. Staging is a very complex system, and there are many nuances. The purpose of today's talk is to really give the basics of how clinicians and others can use the staging system at the very simple, basic entry level. If you need more sophisticated discussions on staging, that's available through the AJC website and a variety of other venues. I have no conflict of interest other than I'm a member of the AJCC. I'm a volunteer for them. What I'm going to do today is go through a very brief history of staging, including information on the UICC and AJCC, describe what staging is, why we stage, who does the staging, what's the role of the cancer registry and the registrar, and how imaging and pathology are used in staging. Finally, at the end of the talk, I'll talk a little bit about how staging evolves and what's the difference that you can expect in the 8th and 9th editions and future iterations of staging. So a very brief historical perspective, staging was based on the TNM concept that was championed by Dr. Pierre Denoy, a surgical oncologist from the Institut Gustave Roussy in Paris. This was the foundation for the Union of International Cancer Control. The North American effort started with the American Joint Committee for Cancer Staging and End Results Reporting, the AJC, which began in 1959. This was an organization jointly formed by the American College of Surgeons, American College of Radiology, College of American Pathologists, College of Physicians, the American Cancer Society, and the National Cancer Institute. The AJC in 1970 adopted objective rules and regulations of the AJCC, which resulted in the formulation and publication of systems of classification of cancer. First edition of the staging manual was published in 1977. The American Joint Committee on Cancer was established in 1959, and it formulates and publishes a system of classifications of cancer, including staging and end results reporting. The goal of all this is to create an acceptable tool to be used by medical professionals for selecting the most effective treatment, for determining prognosis, and for continuing evaluation of cancer control measures. The AJCC is composed of 18 member organizations. Its activities are administered by the American College of Surgeons. The American College of Surgeons requires that for Commission on Cancer accreditation, the AJCC TNM system is used as the major language for cancer reporting. The AJCC and UICC periodically modify the staging system in response to newly acquired clinical and pathologic data, and when we have improved understanding of cancer biology and other factors that affect prognosis. Typically, the revision cycles were every 5 to 7 years. When we got to the 8th edition, however, we harmonized the core and developed new rules and a new way of approaching the staging system. And this resulted in the AJCC publication of the 8th edition in 2016 and the UICC publication of their book at the same time. So let's talk about cancer staging. In order to effectively care for any patients with cancer, it's essential to consider three things. One is the site of origin of the cancer. Where did the cancer begin? Which organ of the body? Second, we want to know a bit about the histologic and biologic characteristics of the tumor. For example, in lung cancer, is it a small cell or a non-small cell cancer? In prostate, what is the grade score? And in breast cancer, things like the receptor status are very important. The extent of the cancer is the globally accepted method of describing anatomic extent of cancer and is called the TNM classification system. Why do we use it? We use it to determine treatment. We often use it to determine prognosis. It helps facilitate clinical research and evaluate the results of treatment in clinical trials in a way that are comparable between the trials. In other words, a common language. And to facilitate the exchange and comparison of information between treatment centers, both nationally and internationally. Why do we assign stage again? Well, it allows us to discuss stage in a multidisciplinary cancer team, which is really the norm now for cancer care. And that team includes primary care physicians, surgeons, radiologists, pathologists, medical oncologists, radiation oncologists, endocrinologists, and a whole team of support people who also contribute to the patient care. It's very important that we're using the same language. It helps us choose appropriate diagnostic workup and treatment. Guidelines include TNM and stage group criteria. It also helps us analyze treatment for recurrence and survival. Data analysis of various factors stratified by stage help us interpret results of clinical trials. Now, some of the very important things to keep in mind is that stage may be defined at different points during the course of a cancer patient's journey through their disease. These time points include the clinical time point when things are first identified, pathologic, post-therapy, recurrence, and sometimes at autopsy. These different classification systems have different purposes and therefore can be somewhat different. So you can't go back and change the clinical staging based on other information that you receive. Patients with similar prognosis of TNM are grouped into prognostic stage groups referred to as stage groups. Stage groups are defined for each classification, clinical and pathologic and others. There are then subcategories of T1, such as T1A and T1B. Keep in mind also there are specific notations such as TX. TX would mean that there's no information available about the primary tumor, it's unknown or can't be assessed. This should be used very rarely. There is no such thing as pathologic M0. This should be called clinical M0 because you don't need a biopsy to prove that something is not cancer. Stage 0 is used to denote carcinoma in situ. The original thinking that led to the TNM system was based on the thought that cancer starts in an organ of origin, it then spreads to local tissues. From there, it can invade lymphatics or blood vessels, and then go on to colonize lymph nodes or other organs, hence the derivation of the TNM way of thinking about tumors. And if you think about the real thought leaders, Halsted thought that tumors began in an organ, it spread locally, then regionally, then systemically, and therefore, if you did a big enough operation, you could cure a cancer. From that perspective, the size of the tumor and the local tumor infiltration mattered. However, Dr. Fisher came along with a different way of thinking about this, and that was that cancers that are going to metastasize do so early in their development. That cancer is a systemic disease from the time we make the diagnosis, and local treatments mean very little if you don't have effective systemic therapy. So biology really matters. The original philosophy again was that stage 1 was basically tumors that were only in the organ of origin. Stage 2 meant there was involvement of regional lymph nodes. Stage 3 went on to say that there's locally advanced disease or non-regional lymph node involvement, and stage 4 was distant metastatic disease. But things have changed. We have more knowledge now about cancer behavior and prognosis, so that strict definition probably isn't as relevant now as it once was. So, small tumors with involvement of regional lymph nodes may actually have a worse prognosis than large local tumors without obvious disease. And very importantly and more current, factors other than anatomic extent of disease have an important effect on prognosis, and they may be combined with anatomic extent of disease to form what are called prognostic stage groups. Non-anatomic factors are generally available in the West, often not available in the developing world. Therefore, the staging system that we use has to maintain the anatomic staging so it can be applied universally around the planet. Prognostic staging includes non-anatomic factors like ER, PR, microsatellite instability, and others that better inform prognosis and treatment by telling us more about the biology of the tumor. So again, basic concepts of staging, TNM, TN, and M are called categories, not T stage, N stage, M stage. there are what are called clinical and pathologic staging. Clinical stage is based on the physical examination, biopsy, and imaging. Pathologic stage is done after removal of the primary tumor. Therefore, little c, TNM applies to the initial presentation only and never changes. I'll emphasize this. General rules: T is the extent of tumor, N, absence or presence and extent of node metastases, M, absence or presence and extent of distant metastasis. I'd implore you to read Chapter 1. Chapter 1 really gives great information about how to use the staging system and what all these terms actually mean. Assigning stage requires deciding on the T category, the N category, the M category, and non-anatomic factors, and these are other non-anatomic factors are used to assign prognostic stage groups. Both TNM and prognostic stage grouping are required to meet standards and provide the best care for our patients. C and P are different concepts. Clinical classification, TNM. Clinical stage classification is based on patient history, physical exam, and any imaging done before initiation of treatment. There's no specific imaging that's required to assign a clinical stage for any cancer site. Imaging study information may be used for clinical staging, and biopsy information on nodes or other sites of metastases may be included in the clinical classification. Stage is both a verb and a noun. As a verb, the treating clinician has a responsibility to stage a patient. As a noun, the patient has a stage 3 breast cancer. So the term stage can be used in a variety of different contexts. Now, pathologic classification is a little bit different. This classification is applicable when a surgical procedure is performed before initiation of adjuvant radiation or systemic therapy. It is composed of information from the diagnostic workup, from clinical staging, combined with the operative findings and pathology review of resected surgical specimens. Again, CTNM is the clinical classification determined before any treatment. PTNM is the pathological classification determined after surgical treatment. In terms of T classification, TX would mean that the primary tumor cannot be assessed. So, for example, if an excisional biopsy was done prior to clinician seeing the oncologist seeing the patient, you may not have the information you need on the tumor. T0 means there's no evidence of primary tumor. This happens sometimes. Sometimes cancer will present with metastatic disease. TIS means the carcinoma is in situ. And T1 to 4 generally means increasing size and or local extent of the primary tumor. NX means regional nodes cannot be assessed. N0 means there are no regional lymph node metastases, and N1 to 3 is used when there's increasing involvement of regional lymph nodes. M0 is there are no distant metastases, as best we know. M1 is there are known distant metastases. Therefore, you should never use the term clinical MX because you don't know. Your clinical assessment and imaging are sufficient to assign M0 as the correct category for when you don't know that there are metastases. Again, we understand that there might be micromets that are unknown to you, but M0 would mean, to the best of your knowledge, based on physical examination, history, and imaging, there are no known metastases. Prognostic stage groups are then based on the combinations of T and M. They're identified by Roman numerals 1, 2, 3, or 4, not numbers. They usually define groups of patients with similar outcomes to help to define prognosis and appropriate treatment, and to enable us to compare similar groups of patients between institutions over time. Some stage groups depend only on the extent of the disease. For example, lung cancer and colorectal really only rely right now on the anatomic extent of disease. So, for example, 65-year-old man presents with rectal bleeding. On examination, there seems to be a rectal carcinoma. It's biopsied, and it confirms it. And then as part of the staging workup, an MRI is performed. The MRI reveals that it's a T3N1A rectal cancer with enlarged lymph node and a T3 cancer based on the MRI study. However, on CAT scan, abdomen and pelvis, multiple liver mets are identified. This would make this a clinical M1A. Going to the table, the patient, N at this point doesn't matter, T doesn't matter. The patient has an M1A metastasis, so they'd be stage group of 4A. Very importantly, the assigning of stage is to be done by the treating managing physician. While the tumor registrars and others help us gather the information, it's the responsibility of the managing physician to assign the stage. This is done in collaboration with a bunch of other people, other doctors, pathologists, radiologists, registrars, and others. But again, the managing physician is the one who assigns the stage. And the reason is that often the managing physician will have information that was not available to the radiologist, for example, or the pathologist. The managing physician is therefore responsible for ensuring all appropriate staging investigations have been performed and assigning the patient stage. Very important rules about stage include the fact that the stage at diagnosis does not change, but patients change. The extent of disease can change after treatment and follow-up, but the original stage sticks. So if the patient is originally a stage 1, but further down the road, we determine that there actually are lymph node metastases, the clinical stage 1 remains the clinical stage and does not change with time. Now, there are modifiers, and things happen in modern care. We treat people in modern ways. So the modifier Y is being used sometimes. So if originally there were no liver metastases, in the case we just talked about, the stage would have been T3N1A M0 stage 3B, and then we might give that patient preoperative chemotherapy for their rectal cancer. The tumor might be downsized. So originally it was one size and now it's smaller. The tumor is now staged as T2 and there are no involved nodes. An operation is performed and there is residual tumor, but no evidence of lymph node involvement. Therefore, after the treatment, the patient is N0. So at the time of surgery, residual tumor cells are seen, mucin is seen in 3 lymph nodes. The stage is now Y, P, TT, N0, M0, and YP stage 1. The Y is being used as a prefix to indicate the stage has been determined after preoperative treatment, often called neoadjuvant chemotherapy. The P is to identify the fact that this is pathologic stage. It is based on the specimen that was removed and the pathologic analysis. The same stage group table shown is used to determine the YP stage. Now, for example, 5 years later, the patient may present with rectal pain. R is used as a prefix to indicate that the stage has been determined after initial treatment and recurrence or after a period of surveillance. So in this case, the MRI reveals a sacral mass, and the biopsy shows this to be recurrent rectal cancer. For some cancers, the stage group depends on anatomic extent of disease and additional prognostic factors. Examples are thyroid, where age is taken into consideration, prostate, PSA, and grade score are taken into consideration, and breast cancer, where ERPR, HER2, and genomic assays are used to provide us more information on the patient's outcome. The stage of diagnosis is recorded in the chart and remains unchanged. Remember to use modifiers such as Y for neoadjuvant treatment and R for recurrence after a period of time. For some cancers, there are not only clinical and pathologic, but also prognostic stage groups. Some prognostic factors might not always be available, especially in low and middle income countries. Therefore, in some tumor sites, such as breast, there are both anatomic stage groups and prognostic stage groups. Staging is used in treatment decision making. So if you look at the NCCN guidelines, they are broken down by T, N, and M, and the stages being used to determine to make treatment decisions. Stage is also important in patient education. Our patients will go to the web and look up information about their cancer, such as at the NIH NCI site, where information is available based on their stage, and that's how they're going to find things. Stage, when done properly, is an indication of prognosis. So increasing stage is generally associated with worse outcome. Staging is also used in population health. If stage is known, then the data can be used to assess the need for staging, as well as the effectiveness of staging, so that if we have an effective screening program, we would expect to see fewer stage 4 disease patients and more stage 1 cancers. And we also want to know if there's concordance with treatment guidelines. If we know the treatment, we can assess if the treatment given is concordant with guidelines that incorporate stage. Further, it helps with resource planning. Different resources needed depending on which stage the patient typically present. The more patients presenting with advanced disease, the greater need for systemic therapy and or palliative care facilities. It also allows us to compare survival by stage across different countries. Now, there are a lot of terms that cause confusion. One is something called stage migration. And this describes a change in the proportion of T&M following the introduction, for example, of a new diagnostic entity such as PET scanning, where we would expect more identification of disease. Stage shift, on the other hand, describes a change in the pattern of stage distribution within a population following introduction of early detection or screening programs, or to a higher stage when access to care becomes limited. An example of that would be COVID, where when there was delay in screening, we might have expected the result in a shift to a higher stage disease. Downstaging means describing a reduction in T or N category after neoadjuvant therapy, and downsizing describes a reduction in the size of tumor after neoadjuvant therapy. Other terms that cause confusion are downstaging, which describes a reduction in T or N category after neoadjuvant therapy, or downsizing, which describes a reduction in the size of a tumor after neoadjuvant therapy. But remember, stage diagnosis remains the patient's clinical stage, even if the tumor shrinks. The original assigned clinical T&M stage is the same. But things change, and diseases changes. For example, we have new knowledge. Genomics in breast cancer provides a very powerful indicator of patient outcome, even more so often than anatomic features. Also, we discover new diseases. Oropharyngeal cancer was described, but now we know that HPV-related oropharyngeal cancer is a different disease with different behavior. Going back to breast cancer is now understood to be a disease with different molecular characteristics that can be identified by gene expression, IHC proteomics, next generation sequence, and other molecular techniques that originate in breast epithelial tissue. These different subgroups have different prognoses, different patterns of recurrence, different patterns of metastases, and different sensitivities to available therapy. So simply relying on T, N, and M, as we did historically, no longer is relevant for breast cancer. Anatomy does provide some prognostic information to support planning, but it's insufficient for prognosis and therapy, so we must include non-anatomic features to define prognosis and treatment. Additional factors such as grade, HER2 status, hormone status, and genomic assays are now part of the prognostic group, and in conjunction with an anatomic information on the tumor, and the nodes and metastases, they're incorporated into what's called a prognostic group. Anatomic staging is based solely on extensive cancer and is intended for use in settings in the world where biomarkers are not necessarily available. However, in the US, where biomarkers are available, clinical and pathologic prognosis stage tables should be used. Here's an example from the 8th edition on the prognostic table, where you can see the TN and M are in the first column. They are then modified by grade, HER2 status, ER status, and PR status. Based on all of those, you can derive the stage grouping. It used to be that you could memorize these tables, but I think there are over 400 different elements in the tables now, so you really must use the table. There are challenges. TNM, again, largely limited to anatomic factors, no biologic information, and creates very large bins of patient. TNM doesn't meet the need of clinicians and patients, as it's still relevant. And then but it really has to be, because not everywhere will all the other factors be available. So we still need something for worldwide use. So the TNM categorization still remains very, very important in cancer treatment. What's been evolving since the last treatment? Well, there are revolutionary changes in molecular underpinnings of cancer, oncogenesis, progression, etc. There are all kinds of new high output testings that are available that we use in our clinical practices. And the informatics and computational ability to analyze these data and produce nomograms and tables is astounding. There are also new diseases. HPV-related squamous cell oropharyngeal cancer behaves differently from squamous cell oropharyngeal cancer that's related to smoking. The TNM system was developed for smoke-related oropharyngeal cancer, but when applied to HPV cancer, the survival curves for stage 1 and 2 and 3 and 4 overlap. In the 7th edition, TNM did not work for HPV-related disease, so a new separate classification has been developed for HPV in the 8th edition and going forward. The 8th edition was a great improvement over previous editions. It used integration based on all kinds of factors that weren't really included before. There were data elements from levels of evidence, precision core, chapter templates, new chapter headings, in a tabular format. The 8th edition was published in 2016 and was was intended to be used after January 2018. Again, please read chapter 1. Each chapter, the outline of each chapter is similar, and that was an organizational thing that we did for the 8th edition. Just to put it into perspective, it took 450 volunteers, 18 expert panels, and an editorial board consisting of 19 volunteers, 6 oversight core groups, 25 core committees, and countless hours by dedicated AJC staff. It introduced what was called structural authoring that allowed better editing, and it was the introduction of what was called an API, which is an electronic platform that allows us to present this data in a variety of different ways. So moving from the 7th edition to the 8th edition was a huge leap and a lot of work. Again, 18 panels, 420 contributors, 181 institutions, 22 countries, 6 continents, and an expanded editorial board. But there were persistent challenges. Again, we recognize that TNM is limited. It doesn't meet the needs, but we do need to retain TNM. Again, there are more molecular underpinnings of cancer. We know a lot more about oncogenesis, progression, resistance, et cetera, than we did before. There are mutational analyses, informatics, and maturing data. So what's happening now? We continue to look at every disease site, and we've made several different changes in how this work is being presented. We've gone from what was the staging manual, which was a large, heavy book that had every cancer in it to what we now call the cancer staging system. The goal is to make sure that for every disease, cancer staging is current, evidence-based, and meets the needs of clinical care and surveillance community. It's not true or accurate that every cancer changes at the same pace. And so rather than waiting to do an entire new 9th edition as one volume, this is going to be published as the science dictates. So the evolution is we will use the 8th edition until the version 9s are available for each disease site. And we will continue to communicate with everybody about when these things are available. Unlike before, you can now buy the version 9 of the AJCC for each disease site, and it's available on Amazon for a very reasonable price. And as an example of all the steps that go into when we are ready to complete a stage system, this is just a very large, complex table identifying how we break down the steps to know when we should make a change. The time frame for some of these, and you can see this one for non-endocrine tumors, is very extensive and takes a while to be completed. The version control will allow for minor corrections when we do this. We will clearly indicate the effective date for when the new system takes place, and everything will be done in a standardized format. There'll be clear indications of the cancer covered in the protocol and those that are not staged. The stage rules will be easier to visualize. Common staging scenarios will be provided, and there'll be survival curves and additional factors for treatment included. It's widely available. It's in the electronic health systems. It's available for sale. There are a variety of ways you can get that. Some of it is available from our website. And again, you can purchase for a very modest price the staging manual for the 9th edition as those are completed. Most libraries have access to the staging manual, the 8th edition, and so there are a lot of ways to get hold of this. What's coming next? New versions for 2024 will include vulva. The protocols will be available for purchase this fall, 2023. Neuroendocrine tumors will be available January 2024, and an updated version 9 protocol will be available to licensees. Thoracic sites are being reviewed. Protocols would be available for purchase in the fall of 2024 is our expectation, and head and neck January of 2025. Plans may change as things emerge in the protocol production process. This is a very involved process, but we'll keep you informed. Please use the website. It's got a lot of very valuable information, and it's a way to stay current and determine what the most current staging system is for the disease you're interested in. So in summary, the AJCC cancer staging system is the language of cancer. It's used to classify the extent of disease, help define treatment strategies, and to analyze and compare results of clinical trials. The 9th edition will roll out as new data is available. Please stay tuned. Thank you very much for your interest.